Hi, ladies and gentlemen. I'm Dr. Markin, and today I'm joined by my friends and worldwide experts. Well, why we are here? What to give our patients? We recently asked our colleagues, so do you give phlebotropic therapy in your practice? And 92% would say yes, they would give it to people with a CVD. And then we asked them, so do you use those drugs on your relatives or on yourself? And yeah, the number didn't change. They said, yes, we would recommend it to ourselves or to our relatives. And the next question was, what are your guidelines? And they said clinical recommendations, clinical guidelines. And others said some publications, some articles, some randomized clinical trials, those primary trials that give you this picture of the world, but the key answer was clinical guidelines. And we will look at clinical guidelines to see that diosmin, different forms and different names, it's very complicated, even in the best clinical guidelines. And to put things in order, I will ask our guest Evgeny to talk about diosmin and clinical guidelines. What should we be guided by to give diosmin right to make it as effective as possible for our patients? Evgeny? Well, we do need those drugs in our clinical guidelines because it's always about microcirculation, membrane penetration, endothelium penetration in CVI and CVDs, and if you do not have pharmacological influence on this biochemical mix, we can't resolve our patients' problems because surgery and laser are impossible to deal with all vein diseases. We need pharmacological tools. But to choose the right medication, the right pharmacological tool, we need some information on what to give our patients. And evidence-based medicine is very important here, and it's based not only on scientific publications and on research data, but also on the case, on the patient, on their preferences, and on our own experience and communicative skills. And clinical guidelines are just a point of reference. It's not an instruction, it's not an order. This is just something for you to keep in mind. And we need to consider the patient's interests as our highest priority. There's William and Mayo said this back in 1910, that the patient's interests are of utmost importance. I'll try to explain. In terms of research, we do not have a better, the best phlebotomic drug. So we need to actually know what is the objectives, and we need to find the best solution based on that. We can't solve the patient's problem if we don't know anything about this problem. So what's important here is to communicate with the patient to find out what his or her problem is and why they came to the doctor. Well, some venous symptoms could be of no importance to the patient, or they could be of great importance. There might be some hidden problems. Well, interventions are not always required here. we are surgeons. You see varicose vein, you reach for your laser with your scalpel, and interventions are not always needed, and the surgery cannot deal with all problems. And patients' preferences too. We might believe one tactic to be the best, and the patient could be of a completely different opinion that we need to find out. In terms of evidence, of course, there's the hierarchy of evidence always. Even in this hierarchy, studies have different level of quality. On the top of this hierarchy, you have randomized studies with meta-analyses, and the golden standard for efficacy evaluation is randomized control studies. That's true, but even on one and the same step, studies could be of different quality. So systematic research, if it's based on low-quality research, it's unlikely to give you a reliable guideline. Of course, you need to take into account, human error and conflict of interest. That's why you need clinical guidelines. That's where professional associations and communities play a role to consolidate our knowledge and expertise. Of course, you need your own data analysis skills too, and I will try to demonstrate it in my presentation. So evidence-based pharmacophlebology is a situation when we drop stereotypes and cliches, when you formulate the goal and identify the number of medications that can be used here to pursue your objective, and take into account the data available about those medications. And the quality of the research paper is not a synonym to the low or high quality of the drug. For symptomatic therapy, it's important that you use trial therapy, because sometimes you don't know whether this medication is going to work for this specific patient, whether or not this specific patient is going to have some side effects or something. In regards to drug-to-drug comparison, you need, direct comparison of high quality, no indirect ones. They can't give you any useful information. So I'll give you an example of a very strange systematic survey with meta-analyses. So it's supposed to be on the top of the evidence hierarchy, but if you compare the efficacy of this substance, so it can reduce the circumference by 0.6 millimeters and placebo by 0.1. The difference seems to be substantial, but the z-score here is used for evaluation, and it can only be used as for parametric analysis if you do work with groups with correct distribution of patients, normal distribution of patients, and it must be proven. And it wasn't in this study. So is this statistical tool applied correctly? The primary source of meta-analysis is 4 papers comparing Ruscus to placebo, and they're not very substantial. It's very unlikely that few patients would be sufficient to compare the medication and the placebo, 20-25 people, and in 2 out of 4 studies, there was no effect, and in the other 2, there was some effect. So this kind of studies, raises questions for me, and I wouldn't use these results in my practice. In terms of clinical guidelines, let me just give you a brief overview of phlebotropic drugs in the current guidelines. In the Russian guidelines of 2018, all those phlebotonics, phlebiprotectors, and so on and so forth, and diosmin is included here. It has anti-inflammatory effect, and others. And it's an effective drug for fighting almost all kinds of venous symptoms. So they are included in the European Society of Vascular Surgeons guidelines. Well, in the Russian recommendations, diosmin and other flavonoids are indicated as medications with no experimental data. Actually, this table came here from European guidelines of long ago, and of course, we should have analyzed the primary sources of information that we didn't do when making those guidelines. Hopefully, we will correct this in the future. On diosmin, there's a whole series of experimental studies that show its activity in different areas for venous symptoms and venous insufficiency. And this is an example of diosmin effects in clinical trials with clinical output. So the evidence base is quite large, and if we had taken this into account when making those new guidelines, this diosmin effects table would have looked completely different. But let's get back to the guidelines. So the recommendations of the American Venous Forum: inactive drugs are recommended without any specifying any specific drug. Cochrane study of 2020: flavonoids, diosmin, quercetin without any subgroups of phlebotomics. And very interesting data that our colleagues in proctology are based on a number of clinical guidelines where flavonoids are used. And it's one of the most fundamental guidelines in coloproctology of 2012. So flavonoids, without breaking into groups, can effectively reduce bleeding and itching in coloproctology. So you can see the same in Italy, Italian coloproctologist, Japanese, French, US. So in the US, they did their own meta-analysis, 14 randomized studies, and they also came to the conclusion that diosmin and some other flavonoids can effectively stop bleeding, itching, and hemorrhage. So of course, we have the same in the Russian national guidelines, without mentioning any specific drug. So to conclude, we do need phlebotonics, venoactive drugs. We cannot call any specific drug as more or less effective, so we need trials, and my colleagues will probably talk about it. There's no dose-dependent effect that can develop continuously. So please join our group of phlebologists on Facebook and our Russian Phlebologists Association. Thank you. Thank you very much, Evgeny. As always, very detailed review of guidelines, and not only Russian guidelines, but also Japanese and other countries. So what's the idea? Phlebotonics, flavonoids, diosmin, many different names. And they're all mentioned in those guidelines with different level of evidence-based studies. And you're saying that you need direct comparison. We have pharmacophlebology. So from pharmacophlebology, let's move to clinical phlebology, pharmacology. All right, let's talk about clinical pharmacology. Let's do this direct neck-to-neck comparison. Phlebotonics and flavonoids on good evidence-based level. So good afternoon, good evening, ladies and gentlemen, depending on your time of the day. I will talk a little bit about bioflavonoid pharmacology and primarily about diosmin pharmacology, because it's diosmin that is probably the best representative in the flavonoid group. So when we talk about any medication, any drug, from a pharmacologist's point of view, not from a surgeon's point of view, because surgeons their lives are easier, and I will show that on my last slide. In terms of pharmacology, we need to take into account pharmacokinetics. That's basically what your body does to the drug. And in terms of diosmin, let me talk about how it's absorbed. Then it's pharmacodynamics. This is what today's drug does inside the body. And of course, clinical pharmacology implies not only evaluation of those pharmacological parameters, which are the basic ones, but also the consequences of using those drugs in people. Let me start off with this slide here. Not to show you that I know different, formulas of different flavonoids. What I want to show here is that the moleculars are really very, very close, very, very similar to each other. We have about 5,000 flavonoid molecules these days, but there are several that stand out. So it's diosmin, effective drug, diosmethine, then this hesperidine, because you have the so-called macronized fraction, which includes not only diosmin but hesperidine. It's quercetin, which may not be very popular in the Russian Federation, but it's widely used in the world as nutritional supplements. And hydrosmethine. It's like diosmethine, but it has this a little tail down there. It's also a molecule which was included in the systematic survey that Evgeny has just quoted from. So let's start with diosmin. Diosmin is a prodrug. It's a molecule that turns into a working substance in the human body. So here you can see this diosmin structure. It's collected to two carbon leftovers. So what happens is this: after it's applied, it gets into the intestines. The intestine flora starts eating off those glycoside groups, and diosmethine is left behind. That's what it looks like. And it's this substance that gets through the bowel wall and gets into the blood plasma, and then it's connected to the acid and is removed from the body. So the primary question is, why am I showing you this peak? And why am I talking about diosmin getting absorbed by human body? They often ask me this question. The substance macronization, how important is it? How important is it that the macronized substance will accelerate the diosmin absorption? To some drugs, we say yes, macronized will speed up absorption and will speed up reaching maximum blood plasma level. For diosmin, that's not quite true. You can't say that macronized will make absorption faster just because it must be transformed by the bacteria first. Then hesperidine. Isn't important to have hesperidine in the macronized drug. And there was a very interesting study here. It's a pharmacokinetic study, and they got surprising data. Patients were given diosmin with no hesperidine. It was pure diosmin. And suddenly, curve 2, after some time, diosmethine level goes up. Of course, it's absorbed by the body, and suddenly you start getting hesperidine. Where does it come from? Well, I think it comes from diosmethine by the same bacteria living in the intestines. The next pharmacokinetic aspect: how do we dose those drugs? Dosage. In surgery, phlebologists, they dose drugs very slowly because phlebology, you don't need fast stationary dose or stable dose. And proctologists, and the diosmin is used in proctology too, so they see patients with acute hemorrhage and they want fast effects, so they have a different route. They give them higher doses of this drug, and the curve too. See, the concentration goes up much faster. So to give it the CSS level much faster, to get this effect much earlier, just because, patients, the complaints they have, they create more problems for them than in phlebology. Pharmacodynamics. What does it do to your body? Diosmin. It has what we call pleiotropic activity. For diosmin, there's a number of targets, number of processes it can affect, but in experimental pharmacology or pharmacophlebology, that's the first time I've heard it today. So thank you, Sergey Markin. So we're going to use it going forward. So in experimental phlebology, we have diosmin influence on vascular walls. So basically this drug increases venous wall tonus because it can accumulate selectively in venous walls. So what are the chances? Yeah, I apologize. Actually, the mechanism can be described quite clearly. It's done through noradrenaline accumulation because it blocks this enzyme. It blocks the enzyme that degrades noradrenaline to norepinephrine or to norepinephrine, depending on what you prefer to call it. So norepinephrine or noradrenaline in the vascular wall results in higher venous tonus after you use this diosmin. Diosmin is it dose dependent? To some extent. For most drugs, we can observe this dose dependency. It's this classical S-shape curve, pharmacodynamic curve. So on the X level, we have dosage or concentration, and on the Y-axis, it's response, S-shaped. So at first, as we increase the concentration, the response does not go up much because we are below the threshold. Then the threshold is overcome, your target starts responding, and you get into this linear area. The higher the dosage, the higher the response. And then you run out of targets. No matter how much you increase your dosage, your response from your targets will not be proportional just because it has reached its peak, and this curve has plateaued. It's flattened out. It doesn't grow on the y-axis. The response isn't growing. Speaking of doses, this 600 milligrams, where does it come from? Diosmin 600 milligrams. In the experiment, it was the dosage when the curve started flattening out. So if you further increase the dosage, you will not cause a substantial increase in response. And the last point, of course, is clinical data. You can talk theoretically for as long as you want, but you must confirm, you must prove that you are getting clinical response from patients. Otherwise, your theory will remain theory. There's been a lot of research done on diosmin since the middle 1980s, and quite a lot of publications have been issued. Well, we love meta-analyses. Yes, it's one of our weaknesses. We love meta-analyses. And the role of bioflavonoids was researched in meta-analysis. It was proven they are good. They can be used effectively in CVDs, and there were diosmin and androsmin as model drugs here. So one more question. Which one to choose? Which is best? Which will work best? Micronized flavonoids or purified, clean diosmin? Pharmacological companies don't like head-to-head studies when you compare one drug to another, because in these studies you know by gut feel that you will see no difference. Well, so there's been quite a few studies in the past 30 years conducted and published, and except for one research in Gospit in 1979, where this micronized form was compared to an artificially produced non-micronized. It was not commercial diosmin, it was some substance. In this study, it was allegedly shown that micronized is better, but honestly, when I looked, digged into this article, I found some methodological problems. Of course, we don't have enough time to talk about it now, and well, this article was published back in 1989, and it was a long time ago. So those other studies that were published later, diosmin was compared versus micronized fraction using clinically important endpoints in phlebology. And we didn't see any significant results. But the most interesting one was the study that was published this year, and where they compared diosmin 600 milligram versus micronized fraction which contained 900 milligram diosmin and 100 milligram hesperidine. And basically, our colleague Marsio Штайнбруch will talk about it in his presentation, because he is one of the leading authors, one of the leading researchers in this area. So I don't want to get into his field, so to say. Just one point. According to this study, there were no statistically significant differences. And one more painful question. It's the question of generics. Yeah, I'm not saying that generics are bad. But the professional community, we don't like generics, because they bring this, aura of lack of evidence, because generics are registered, are licensed based on biological equivalency studies, not based on clinical studies. So generics need to be compared to something, and there are two reference drugs in the Russian market. So if you register a generic that only contains diosmin, then Phlebodia 600 will be reference drug, and you need to compare it to this one. If you register a micronized substance, then the reference drug will be Deflon or Detralex. Well, this is it. Like I said, pharmacologists, find it harder because they stay within pharmacotherapy. Surgeons, they can cut. Thank you very much. Well, was it some sort of criticism of surgeons or what? Thank you very much, Oleg. And I liked the word plateau out, asymptotic. It's like saying there's no difference between 600 and 900. If you know that 600 is going to work, then, well, there is some difference between 6 and 900, yeah, in terms of weight, amount, price, etc., but not in terms of response. We have suspicions that this curve, the response curve, is getting asymptotic. Between 600 and 900 milligrams. So you increase the dosage, but the response does not go up. And what Oleg is showing you basically emphasizes the fact that you can increase the dosage. All right, now our next speaker is Marsio Штайнбрух. It should work. Hi, Marcio. So if you would like to share with us the results of your unique study that Oleg has already announced, and that should, I guess, confirm the conclusion that 600 is equal to 900 in terms of clinical effect. Marcio, over to you.
Thank you. I will share my slides. Several authors have conducted clinical studies on the use of pure diosmin in chronic venous insufficiency. And these are what we are going to expose in this presentation. I would like to thank Inoterra Laboratory and Dr. Vladimir and his team, which have given me the honor of being here today, and thank again for the opportunity to participate in this study that I'm going to present now. We studied the non-inferiority of 600 milligrams pure diosmin compared to the use of 900 milligrams micronized diosmin plus 100 milligrams asparagine in chronic venous insufficiency. This is the first study to compare pure diosmin at a dosage of 600 milligrams Phlebodia with the micronized purified flavonoid fraction of 1000 milligrams, both administered in the form of a daily tablet for 6 months. The study period for both groups followed the indication of minimum treatment duration and the description of the characteristics of Daflon 1000, which is in the Brazilian market. This is a prospective, single-blind, parallel, randomized study with a total duration of 6 months for the patient. There were 4 visits at month 0, 2, 4, and 6, and controlled by phone calls by the researcher in month 1, 3, and 5. The study's main objective was to evaluate the clinical non-inferiority of pure diosmin, 600 milligrams Phlebodia, taken once a day compared to micronized diosmin, 900 milligrams, asparagine, 100 milligrams, from the reference brand also taken in the same way. The primary outcome was a 50% reduction in the intensity of lower limb symptoms on the visual analog scale. Secondary objectives included the comparison between both for oral acceptability, tolerability, global patient satisfaction, and overall physician satisfaction. The study had the participation of some Brazilian university centers. University Center Serra dos Órgãos, Rio de Janeiro Federal University, Fluminense Federal University, Santa Casa, and Rio de Janeiro Estadual University. The following doctors participated in this work: Marsio Штайнбруch, me, Carlos Nunes, Romualdo Gama, Renato Kaufmann, Gustavo Gama, Mendel Surmacher Neto, Rafael Nigri, Natasha Citrimbaum, Lissa Brauer Oliveira, Isabelle Bertenat, François Verrier, and Mauro Geller. 120 patients over 18 years old non-pregnant, were included with symptomatic CVD of the lower limbs, CAEP grade 0 to 3, and symptomatics of 20 to 60 millimeters on a visual analog scale of 100 millimeters. The visual analog scale globally assessed the most symptomatic leg with the following symptoms: heavy legs, painful legs, tired legs, swelling legs, and or tension in the legs. Visual analog scale was filled out by the patients themselves. Sorry. We also classify oral acceptability. Swallowing was assessed by a visual analog scale of 100 milligrams, rated by the patient with 0 millimeters, very easy to swallow, up to 100 millimeters, equal very difficult to swallow. As we had 6 dropouts in the middle of the treatment, the number was reduced to 114 patients with a mean age of 44.4 years who were randomly divided into 2 groups of 57. 90.4% of them were female. Symptoms improved in both groups with mean change adjusted on the visual analog scale of minus 24.9 millimeters in the Phlebodia group and minus 22.8 millimeters in the Daflon group, corresponding to about a 50% reduction in the intensity of baseline symptoms. The reduction in symptoms was more pronounced in the Phlebodia group in the first 4 months of treatment, being the second month during the first evaluation the most significant one. The difference between the groups was minus 2.1 millimeters for a non-inferiority margin set at 20 millimeters. Therefore, non-inferiority was demonstrated. The difficulty in swallowing the tablets was significantly less in Phlebodia compared to the Daflon group, 9.4 millimeters and 54.7 millimeters respectively at 6 months. In conclusion, it has been proven that pure diosmin with 600 milligrams is not less effective than micronized diosmin 900 milligrams plus hesperidine 100 milligrams, with a marked reduction in symptoms throughout the study, being significant in the second month. It's also associated with greater ease in swallowing the tablet. The acceptance of Phlebodia tablet was much higher, near 5 times higher. The researchers' overall satisfaction was good or very good, comparable for both drugs, 79% in the Phlebodia group and 76.8% in the other group taken for 6 months. This suggests that 600 milligrams is the dose of pure diosmin sufficient to relieve venous symptoms. And these general results reinforce that the use of pure diosmin at a dose of 600 milligrams once a day is equally effective, being easier to swallow compared to the tablet containing the micronized form of diosmin combined with hesperidine. If we have enough time, I will show the summary of 2 other studies it will be fast. Henriet, in 1995, studied pure semi-synthetic diosmin at 600 milligrams daily versus 1,000 milligrams of diosmin with asperidine daily in patients with chronic venous insufficiency. The objective was compare the efficacy of pure diosmin 600 milligrams a day versus a combination of 450 milligrams of diosmin plus 50 milligrams of hesperidine twice daily. It's different for our study, twice daily. 69 women from 18 to 45 years old with venous symptoms related to venous insufficiency of the lower limbs participated. Duration of treatment, 1 month. In conclusion, in both groups, there was a significant reduction in symptoms, with a difference of 12.5% favoring the group treated with pure diosmin. And satisfaction was also greater in the same group, with 10.2% more satisfied and very satisfied patients. And the last study, Maroshinsky in 2004, he did a randomized comparative study, and the objective was compare the clinical effectiveness of pure diosmin 600 milligrams per day versus a combination of 450 milligrams of diosmin plus 50 milligrams of hesperidine taken twice a day. 119 women between 20 and 60 years of age participated. Duration of treatment, 1 month too. The conclusion, during the 4 weeks of observation, diosmin 600 milligrams has been shown to reduce symptoms related to venous insufficiency of the lower limbs. The influence in reducing these symptoms were noticeable after 1 week of treatment. Both medications were safe and well tolerated. But a more intense reduction in night cramps was observed in the group treated with phlebodia, with a significant reduction in 14 days. Thank you very much.
Thank you very much, Marcio. It's an excellent opportunity to hear about good quality research presented by the author and the main participants and the manager of this research. Thank you, Marcio. Great job. And I came across this study several months ago, so it's an excellent opportunity to get this information from first hand, so to say. So as we can see, 600 is no different from 900, and it's not just this study, it's also, 1994, 95, 2004. Well, on some indications, phlebodia is more efficacious, but that's not important. What's important is that 600 is equal to 900. Normally you do all kinds of 1995, 2004 and 2020. 600 is equals 900. All right. From the clinical point of view, we know that. Now I'd like to ask a couple of questions to our participants from other countries, if I may. Serbia, is Serbia here? Dragan Milic, are you there? If you're there, I'd like to ask you this question. In a drugstore, in a pharmacy store, so which drug is used in Serbia? Because 600 milligrams is equal to 900 milligrams. Do you have any preferences in Serbia?
We have clear preference towards phlebodia. Phlebodia is phlebotonic drug that we use for more than 15 years with great success. As Evgeny said at one point, it is very difficult to clarify the evidence-based medicine, saying and proving the effectiveness of any drug. When we speak about the studies, it is always very, very difficult to clarify objective from subjective parameters, and that is the most difficult problem. So I saw one slide saying that the American Venous Forum is suggesting and is recommending phlebotonic drugs, which is true, but all these studies and all these recommendations have only 2B level of evidence and level of recommendation, which in somewhat is a problem. In our opinion, the most important thing is the feedback that we have from our patients. And when we give to our patients Phlebodia, we have extremely well, and we are very satisfied with their response, which is almost excellent. And about 90% of our patients have positive feedback with good reference to Phlebodia. In my opinion, maybe it is the most important that the patients who have in C classification C0 symptoms, like colleague said, restless leg syndrome, heavy legs, and so on, we often use it as a differential diagnosis for the treatment. We give to these patients Phlebodia, and in 70–75% of cases, we have a positive feedback with the lowering of the subjective symptoms from our patients. So in our opinion, this is the most important thing, and we have this positive feedback, and yes, our preference in Serbia is definitely Phlebodia for more than 15 years.
Thank you very much, Dragan. So it's great that you not only, give this drug to the patients, but you expect feedback. Of course, it's important to get clinical effect. So when we are saying that this molecule is working, the patients need to have compliance, and this acceptability. It was mentioned in Marcio's presentation. So Marcio, can you? I would like to ask you a question, if I may. What is this acceptability that you talked about in your presentation? So is it the same as compliance, or is it different from your point of view? Acceptability and compliance. And what's the most important thing in terms of compliance and acceptability?
In our study, we saw that the acceptability of the Phlebodia was higher. And the reason for the patient to maintain compliance with the treatment is the comfortable dose of 1 tablet a day and ease of swallowing the tablet. In our study, the acceptability of group Phlebodia was 5 times greater than other group. So the effect is the same. Phlebodia is not inferior, it's the same, but it's easier to swallow. Then the patients get compliance for the treatment. And I know I can see this in my patients.
Thank you very much, Marcio. Can I ask you a personal question? Do you give Phlebodia to your patients? It's such an efficacious drug. Do you use it in your work? Do you give it to your patients in Brazil? You, your colleagues, do you give it to your patients?
Could you repeat, please?
Do you give Phlebodia to your patients, you personally and your colleagues?
Yes. Since Phlebodia was in Brazil, when it entered in Brazil, I used to give to my patients the Phlebodia. And in my experience, I can see the patients, the adherence is better to the use of Phlebodia, And the effects, too, I can see they are more pronunciate, the effects. So we use phlebodia, and my near colleagues too. My close colleagues.
Thank you very much, Marcio, for your honest question. I'm interested in Brazil. So one more question for you, Marcio. So this phlebodia, when did it come to Brazil? And is it part of your clinical guidelines already? Or is it included in your guidelines? Or are you planning to include phlebodia in your guidelines in Brazil based on your clinical studies?
Phlebodia entered in the Brazilian pharmacopoeia now in 2020. So in the guidelines, the Brazilian guidelines, it doesn't have the pure diosmin. Only has the micronized diosmin plus asparagine. But after this study, we are looking for to include the pure diosmin in the Brazilian guideline. It will be done soon. It will be done soon.
Thank you very much, Marcio. So as you can see, phlebodia comes to markets, new drugs, and it's efficacious. 600 equals 900, unique acceptance and compliance. And I'd like to turn to Evgeny. Evgeny, we've just talked about several, compliance and acceptability factors. It's about price, shape, dosage. So what are the key factors in terms of patients' compliance? Well, to avoid confusion, let me share my view of the term. Acceptability is a characteristic of the drug. It could be, convenient and cheap, or inconvenient and expensive. Would you like, injections or bitter drugs? And when we were little kids, remember those things? And compliance is about the patient's attitude, and the acceptability of the drug makes compliance better. What's also important is how convincing the doctor is. That's it. So, Oleg, what do you think? Or yes, I will compare with Dr. Evgeny, because these are two different terms. Acceptability includes everything, price and shape, and adherence, compliance. This is basically how well you comply with the recommendations, the patient compliance with the doctor's recommendations. So you're saying it must be convenient for the patient to take this drug, and the price must be suitable, so people can afford it. So we need to have 600 milligram drug that works as a 900 milligram, but at a lower price. Marcio mentioned that phlebodia is smaller in size and it's easier to swallow. So on this slide here, if you can see it, that's the price of 600 and 900 milligrams and sachet. So if a big tablet pill is difficult to swallow, so we need a new shape that is easier to swallow. And then the price is plus 70%. So compliance and acceptability. So if we increase the price, it's not going to work, is it? So minimum price with all the clinical effects that you can get from 900 milligrams. I'd like to discuss one more thing with you. So can you take a generic drug speaking of the price, so for example, the sachets are very expensive, 900 milligrams, expensive. Even phlebodia is expensive. Why not take a generic? What do you think, Evgeny? Can we expect the same efficacy from a generic than from the original drug? So people go and buy it. Is it going to be as efficacious as that? Because we have about 15 generics in the market. Well, I wouldn't say it's like black and white. I wouldn't say the generics are an absolute evil or something like that. Oftentimes, they're good. And of course, if it is a generic, we need to have some clinical studies with the evaluation of its safety profile. And it's not just about, clinical efficacy. It can be as efficacious as that, but because of manufacturing problems, process problems, it might have some side effects that the original drug doesn't. So for me, it's easier to give the patient the original drug, not a generic. I will only turn to a generic if the original drug is not acceptable to the patient and there is clinical studies for the generic. Well, if you have clinical studies for a generic, it's not quite a generic, I would say. What do you think, Oleg? Well, from a pharmacologist point of view, let me comment on from a phlebopharmacologist point of view. What is diosmin generic? Show me a study, show me a publication with bioequivalency results. How did you measure the concentration, diosmetin or diosmetin glucuronide? Because diosmin pharmacokinetic studies are not an easy thing to do. I've never seen such things. Study results are not published, they are filed as reports to the regulators, and it's like a black box. And the regulator will license the drug. If a generic manufacturers published their studies, we would be able to conclude on how bioequivalent they are. Without this kind of studies, I will not take your word for it. So I cannot comment on whether or not you can use generics to replace original drugs. All right, we don't believe anyone, we only believe high-quality research, high-quality studies. What do they tell you? Original drugs, good dosage, 600 milligrams is equal to 900 milligrams. Several forms, phlebodia, it's easier to swallow. Randomized clinical study shows it's easier to swallow. It's better in terms of acceptability in pursuing our goals with the patients. So I'm sure some of our guests might have comments or questions or ideas to share or impressions to share because we have actually raised a number of issues, randomized, clinical, blind, double-blinded studies. Sometimes we live in stereotypes, sometimes we are mistaken, and they just set the path for you if you want to get clinical effects for your patients. All right, so Marcio, if you can hear me now, so we have analyzed our studies and do we see how we should move on? Have we touched upon everything or there is something else we should talk about? 600 is equal to 900 or do we still have any doubts about it?
Yes, 600 is equal to 900 and easier to swallow. That's the point. In Brazil, we don't have pure diosmin generic pure diosmin. So it's good because the patient will not change our prescription. And the other, we have generics but the same, it's not the same effect, unfortunately. And it's the Phlebodia showed us the superiority with the is to swallowing, but the effect is the same.
Thank you. That's an excellent choice. It's easier for you. You have original drugs and now a new original drug, and I hope it will take its place in the Brazilian market that it should take. And so we look forward to seeing it in the Brazilian clinical guidelines, thanks to your study. Now I turn it over to Serbia. We've talked with the Dragan Milic, and it looks like Serbia is an advanced country here. So Dragan, have we discussed everything, or you would offer some other comments or questions from your side?
Well, yes, I think in the future, a good idea would be to have some multi-centric randomized study with multiple nations. It was an idea that we had for many years, but unfortunately we didn't perform such a study. And I think that we should pursue for some other endpoints. Maybe some endpoints that could be measured objectively, like with plethysmography, maybe with ultrasound. Maybe we're not going to get some answers, but I think that we should expand our viewpoint in these future studies, and definitely the study should be multinational. I have to emphasize the thing, in our opinion, we performed a study, maybe similar like our colleagues in Brazil. We never published this study because this study did show that Phlebodia is superior to Daflon in many ways. We did one trick with the patients. Maybe it wasn't ethical, but we give to our patients 3 months Phlebodia, and we give to our patients in another 3 months Daflon, and we ask them which drug do they prefer. It was interesting that 82% of our patients preferred Phlebodia, and this was definitely the best proof, in our opinion, the feedback that we have from our patients, which drug is, let's say, preferable for our patients. And according to our society, Serbian College of Phlebology, we have recommendations that were brought in 2007 to use Phlebodia for the treatment of the chronic venous disease in old patients, and especially in women.
Well, maybe we can connect Romania. Sergiu, are you there?
Yes, I'm here. Good evening to everyone.
Well, maybe 600 milligrams is really better than 900 milligrams. Sergiu?
Yes, also we have our experience with 600 milligrams. We started to use this pill about 1 year and several months ago, but we started to have a good experience with it. And also I want to propose to all my colleagues that had spoken before, we can make a large study combining our results from all our countries. So maybe I think that this study could have more than 1,000 patients. So in this case, maybe also the medical guidelines would be changed. So we like
Yeah, thank you very much. Well, from the Russian side, 3 of us are ready to participate. So, Sergiu, we will support your idea, and you are welcome to join our group. Hopefully, you will soon be amongst us. And we will do a non-inferiority or maybe superiority study. Now I'd like to turn over to Uzbekistan. Mamur Abdurrahmanov is with us. So Mamur, how are things in Uzbekistan and what do you think of phlebardia? Any preferences in phlebitropic therapy? Yes, good evening, ladies and gentlemen. Good evening, my dear colleagues. So first of all, I'd like to thank you for inviting me to this very interesting conference or session. This information we are presenting here is very interesting and very much needed. We've always been interested in dosages, not only in CVI, but dosage in other problems too. It's all very important questions. Well, of course, Detrolax had an advantage in the first year because it came to the market about 10 or 12 years ago. But in the past 5 to 6 years, we've seen a clear advantage of phlebardia. Number one, it's 1 pill a day, and it's high compliance in CVD patients, and of course the pill size. It's a lot better and far superior than Deflon or Detrolax or those hesperidine and diosmin containing generics. And the studies that we do and in our clinical practice, my clinic where I work, and this is Bukhara State Institute, it's the fatherland of Avicenna. So basically, my country is the fatherland of the great Avicenna, and he talked about these problems, thousands of years ago, and he wrote about these problems. And so we are inclined, and we love this medication, me and my students. Thank you very much, Dr. Mamur. So in Avicenna's fatherland, they use phlebardia, but we should pursue evidence-based medicine. So we need a second opinion. Akram Akhmedov, also from Uzbekistan. Maybe it's not that clear in terms of phlebardia. Akram, are you there? So in terms of preferences in the phlebitropic therapy, so Mamur is saying that it's 100% phlebardia. What about your experience? Well, we use phlebardia in pregnant women and in hemorrhage because that's when patients, pregnant patients, they have placenta insufficiency, and we use this original drug in such conditions. We use it quite often. And it gives us a lot of benefits, and we are now doing a study on other chronic venous diseases, deep vein thrombosis and things like that, and we are going to publish the results of this study very soon. Thank you very much, Akram. All right, so some of you prefer those drugs in some clinical situations, and we look forward to seeing the results of your study. And most probably will be talking about your publications next time. And now I turn over to Belarus. Excellent Belarus. Boris, are you here with us? I apologize, Boris, for calling you by your first name. So how are things in Belarus? Hi, Sergey. Well, I've seen this fight of two original titans for the next 10 years, over the past 10 years, 600 or Deflon. And Belarus, they more often give Deflon in all regions except for Gomel region where I work. Our champion is Flebadia here in Gomel region. Well, originally, the convenience for me was this one time a day, and Deflon now also does one pill a day, but the big pill is difficult to swallow. That's true. But if my patient says that they take Deflon and it helps, I will never pursue them to change their opinion. But I more often give my patients Flebadia. And I'm a surgeon, you know, I often give it after surgery, post-surgically, so to say. But I would agree with my colleagues that what we need to do is a international study comparing those drugs. And of course, you should always prefer original drugs, although we have dozens of those generics. All right, thank you very much, Boris. Now it looks like we have a consolidated expert opinion, so we're comparing 600 to 900, and so we're tilting towards 600. All right, Ukraine. Denis, are you with us? Are you online? Yes. Denis, would you share your Ukrainian experience? We're coming closer to the final point of this. So it's all up to you. The results of this survey are up to you. Which is better, 600 to 900? Yeah, it's a pleasure that this is my mission to make an executive decision. Well, I'm kidding. Of course, you need a consolidated decision. Well, in Ukraine, like in any other country, you have lots of patients who need phlebotomics, and of course, we use them to treat not only CVI of the lower limbs, but in proctology, in mammology, and gastroenterology. In Ukraine, we have over 15 diosmin containing drugs registered, licensed. And when you're considering different phlebotomics, you look at, number one, evidence-based things, because we're living in an era of evidence-based medicine. So it's not just your personal experience, it's also evidence. You know, each surgeon would have like 500 or 700 patients that you give phlebotomics to, and you have a lot of experience with that. And we know that phlebotomics are not used in monotherapy. So I wouldn't say that we should have the last word here, but we can see from studies that there's a lot of studies both for Flebadia and for Deflon and for other phlebotomics, venotonics. But the priority for the patient should be the doctor's recommendation. You know, my teachers and my students, we all look at modern rules, modern medicine rules, evidence-based. So if you have at least 2A in terms of evidence, then the recommendation, the guideline is statistically significant, it's well-grounded, and you can follow those guidelines. If the guideline is even stronger, then no questions. Of course, those studies, they look at different factors. Sometimes it's impossible to do a head-to-head comparison. But I would say that most young doctors will be right if, number one, they give their patients regional drugs on which they have studies, research, results. Of course, convenience. One time a day, much better than 2 times. And of course, the price also matters. It's not the last criterion in prescribing a drug. We have worked with phlebology for over 15 years now, and I've never seen a patient that would be allergic to this drug, number one. I've never seen a patient who would have side effects to this group of drugs. So I think it's well deserved that these drugs are over-the-counter drugs in many European countries. And in recent years, unfortunately, we are all looking at Western countries, and we participate in the European and Western and the US conventions, and we go to European and American clinics. And of course, we make our own opinion of what is going on in different countries with these drugs. All those drugs are used. Well, if it is part of your protocol, of course, you cannot discuss if you want drug A or drug B, but these drugs from this group, they are proven, they are efficacious, and they are well respected by vascular surgeons. So thank you very much for this drug for phlebology. It's it has very good efficacy, tolerability, and I hope we will have it for a long time. So once again, thank you for organizing this event, for giving me this opportunity to speak to all of you there. And thank you very much. I give it back to the chair. Thank you very much, Dennis. So we should start closing this conference. We still have about 10 minutes to go. So as you can see, everything is based on evidence. We've showed you the studies that show you that 600 is equal to 900, and we should also take into account personal attitudes. Well, I was counting, the advantages. Phlebodia, in terms of efficacy, 600 equals to 900. It's non-inferior, and it's well accepted by our colleagues. It's supported by experts from all countries. Some even prefer it better than 900. So Bosnia and Herzegovina, Moldova, France, and other countries, they support phlebodia 600 milligrams. So I can ask you just one question, Evgeny. So we've been talking about 600 equal to 900, but let's get back to this hemorrhage question that you raised. So maybe we should give them 600 one time a day if there is no difference. But there we give several drugs a day. Why do we do this if there is no difference? Yeah, I think we do this because we want to get as much concentration in, blood plasma level, as high blood plasma level as possible, as quickly as possible. So the question if 600 milligrams is sufficient for hemorrhage treatment, so further studies are required. Of course, further studies are required. So Oleg, COVID-19, a person, a patient, 140 kilograms. Would you give him 600 or 900? Well, I'm not. Sometimes, we have obese, comorbid, overweight patients. You're afraid that this drug will not get to the blood because it will stay in the fat, but we don't have this data. So if you have morbid obesity, I'm not aware of this data that you need to increase the dosage. In other words, 600 not only equals 900, it's sufficient for patients. And we have no data that we need an increased dosage. Even with obese patients, you will have clinical efficacy. Right, ladies and gentlemen, it's time to end this unique discussion. It's been my pleasure because we have quickly gone all around the world. We spoke about 600 and 900 evidence-based medicine, and now we can confirm that 600 equals 900, no stereotypes, both from the evidence-based medicine point of view and from our colleagues' opinions. All right, thank you very much. Stay well, stay safe. Thank you for joining us on this international marathon, so to say, with lots of questions and lots of answers. My personal thanks to each and every one of you, especially to Marcio. Excellent presentation. It was a pleasure to hear it from you personally. Also, I'd like to thank our speakers being here in St. Petersburg. So we're keeping social distance, 101.5 meters from each other to take off our masks. And we look forward to seeing you to understand whether 600 equals 900 or better. Thank you.